This podcast is hosted by Will Glomsky. Will is an experienced critical care paramedic working on a ground ambulance. This podcast is purely educational, and the opinions reflected are of the hosts only. This show is not intended to supersede any local protocol or training. This podcast covers educational content surrounding emergency medical services. Welcome to the Midnight Medic Podcast.
Hello and welcome to another episode of the Midnight Medic Podcast, the podcast for EMS professionals dedicated to delivering top-tier pre-hospital care. I'm Will, and today we're focusing on a critical and common condition, pneumonia. Pneumonia can strike anyone, but it disproportionately affects the most vulnerable, making early recognition and intervention crucial in the pre-hospital setting. What is pneumonia? Pneumonia is a lower respiratory tract infection characterized by inflammation of the alveoli. It can be caused by bacteria, viruses, or fungi, and leads to symptoms like cough, fever, and difficulty breathing. While some cases are mild, severe pneumonia can be life-threatening, particularly in the elderly, very young, and those with chronic health conditions. Pneumonia can be classified into different types based on how it's acquired. Community-acquired pneumonia, or CAP, occurs outside of the healthcare settings and is the most common. It's often caused by Streptococcus pneumoniae, but can also result from viral infections like influenza or respiratory syncytial virus or RSV. Hospital-acquired pneumonia, or HAP, develops 48 hours or more after hospital admission. HAP is frequently caused by antibiotic-resistant bacteria such as Pseudomonas or methicillin-resistant Staphylococcus aureus or MRSA. Ventilator-associated pneumonia, or VAP, is a subtype of hospital-acquired pneumonia that occurs in patients on mechanical ventilation. This too develops after 48 hours of hospital admission or 48 hours on a ventilator. These patients are at high risk due to prolonged intubation and exposure to pathogens in the hospital environment. Aspiration pneumonia is caused by inhaling food, liquid, or vomit into the lungs. It often infects individuals with swallowing difficulties, reduced consciousness, or conditions like stroke or dementia. Anaerobic bacteria commonly play a role in aspiration pneumonia. Atypical pneumonia, often called a walking pneumonia, it is usually less severe and caused by organisms like Mycoplasma pneumoniae, Chlamydia pneumoniae, or Legionella pneumoniae. These cases may present with milder flu-like symptoms. Each type has its own set of risk factors and pathogens, making early identification and tailored interventions essential. So who is at risk? Recognizing high-risk patients can help prioritize care and transport decisions. Key groups include infants and young children. Immature immune systems make them vulnerable. Elderly individuals. Age-related changes in coexisting conditions increase risk. People with chronic diseases such as COPD, asthma, diabetes, or heart failure. Immunocompromised patients, including those undergoing chemotherapy or living with HIV or AIDS. Individuals exposed to aspiration risks, such as patients with swallowing difficulties or altered mental status. Smokers. Smoking damages the lungs and reduces their ability to fight infections. Individuals with recent viral infections, such as influenza or COVID-19, which can predispose to secondary bacterial pneumonia. What to look for in the field? Pneumonia symptoms vary, but common signs include fever and chills, often present in bacterial cases, cough that may produce sputum that's yellow, green, or even blood-tinged, shortness of breath, particularly on exertion, chest pain, typically pleuritic, worsening with deep breaths. Altered mental status, more common in elderly patients. Fatigue and weakness, often reported especially in older adults. During your assessment, listen for diminished breath sounds, often heard over affected lung areas. Crackles or rales, which is indicative of fluid in the alveoli. Increased respiratory effort, including accessory muscle use or nasal flaring, tachypnea and tachycardia, common in mild to moderate cases. Pre-hospital treatment of pneumonia. Let's break down the critical steps EMS providers can take to manage pneumonia in the field. Airway management. Ensure the airway is patent. Suction if necessary, especially for patients with copious secretions or aspiration risks. Oxygen therapy. Administer supplemental oxygen to maintain SpO2 levels above 92% or above 88% for COPD patients per local protocol. Use a nasal cannula, non-rebreather mask, or CPAP for severe respiratory cases, depending on patient needs. Positioning. Position the patient to optimize breathing. Often, sitting upright is most comfortable. Avoid lying flat, especially in patients with suspected aspiration pneumonia. Fluid therapy. Dehydration is common in pneumonia due to fever, increased respiratory effort, and reduced oral intake. Administer IV fluids as permitted by protocol to support circulation and hydration. Use isotonic solutions like normal saline or lactated ringers to restore fluid balance. Adjust the rate of infusion based on the patient's age, weight, and clinical condition. In febrile patients, moderate boluses may help combat dehydration and improve perfusion. Be vigilant with fluid administration in patients with comorbid conditions such as heart failure or renal impairment to prevent fluid overload, which could exacerbate pulmonary congestion. Assess for signs of fluid responsiveness, including heart rate, blood pressure, and mental status, while watching for adverse signs like crackles or jugular venous distension. Medications. Nebulized bronchodilators. Consider for wheezing or bronchospasm, especially in patients with underlying asthma or COPD. Antipyretics. If within your scope, treat significant fever to improve comfort and reduce metabolic demand. Antipyretics such as acetaminophen or ibuprofen are effective in managing fever associated with pneumonia. Reducing fever not only enhances patient comfort, but also lowers the metabolic demands of the body, which can be particularly beneficial in elderly patients or those with compromised cardiorespiratory function. It's essential to adhere to dosing guidelines based on patient age and weight, and always check for contraindications such as liver disease for acetaminophen or renal impairment for NSAIDs. Regular reassessment after administration can help gauge effectiveness and guide further interventions. Antibiotics. While not typically administered in the pre-hospital setting, antibiotics are essentially the definitive care for bacterial pneumonia. Hospital teams will select antibiotics based on the suspected pathogen, patient history, and known drug resistance patterns. Commonly used agents include amoxicillin, azithromycin, or ceftriaxone for community-acquired cases, and more potent options like vancomycin or piperacillin tazobactam for hospital-acquired infections. EMS can play a critical role by documenting allergies, recent antibiotic use, or past infections to aid the hospital in making informed decisions. Monitoring. Use continuous pulse oximetry and capnography if available to monitor oxygen and ventilation status. Perform serial assessments to identify worsening respiratory status, such as increased work of breathing or deteriorating mental status. Transport decisions. Prioritize transport to the nearest appropriate facility. For patients with severe hypoxia, hemodynamic instability, or respiratory failure, consider advanced life support or expedite transport. Advanced treatments in pneumonia. While EMS management focuses on supportive care, recognizing when advanced interventions may be necessary is crucial. These include antibiotics administered at the hospital to target bacterial pneumonia, ventilatory support. Non-invasive options such as CPAP or BiPAP can be used in the hospital setting for patients with moderate to severe respiratory distress to avoid intubation. For pre-hospital providers, CPAP is a valuable tool to improve oxygenation and reduce the work of breathing. Ensure proper mask fit and titrate pressures carefully to achieve clinical improvement. In cases of respiratory failure or exhaustion, endotracheal intubation and mechanical ventilation may be necessary. These patients often require rapid sequence intubation to secure the airway effectively. Collaboration with advanced life support teams or aeromedical services may be needed. Post-intubation, ventilatory settings should be adjusted to prevent barotrauma or volutrauma, particularly in patients with underlying conditions such as ARDS secondary to pneumonia. Sepsis management. For patients showing signs of septic shock, early recognition and hospital treatment can improve clinical outcomes. Steroids may be used in the hospital setting for severe inflammation or in certain underlying conditions. Some special considerations. Elderly patients, symptoms like confusion or lethargy may mask the severity of pneumonia. Maintain a high index of suspicion. Aspiration pneumonia. Common in patients with impaired swallowing. Ask about recent choking episodes or dysphagia. Pediatric cases, watch for grunting, nasal flaring, and retractions as indicators of severe respiratory distress in children. COVID-19 co-infections. Consider the possibility of overlapping infections in current healthcare landscape. Document patient history and symptoms thoroughly. Preventing pneumonia spread. As EMS providers, protecting yourself and others from infection is paramount. PPE. Wear gloves, masks, and eye protection during patient care. Wash hands thoroughly after each call. Disinfect stretchers, monitors, and other high-contact surfaces between transports. Encourage high-risk patients to get vaccinated for influenza and pneumococcal pneumonia. Avoid smoking and secondhand smoke exposure. and practice good respiratory hygiene like covering coughs and sneezes. As EMS professionals, your understanding of pneumonia can have a lasting impact on patient outcomes. Remember to ask targeted questions about recent illnesses, chronic conditions, or risk factors. Be vigilant about recognizing subtle signs of worsening respiratory distress, and always document findings clearly to aid the hospital team in formulating a treatment plan. That wraps up our deep dive into the EMS management of pneumonia. By recognizing the signs, providing timely interventions, and prioritizing transport, we play a vital role in improving outcomes for these patients. If you found today's episode valuable, share it with your colleagues, and don't forget to subscribe for more insights tailored towards EMS professionals. Got questions or topic suggestions? Reach out at the Midnight Medic Podcast at gmail.com. Stay safe, take care of your patients, and take care of yourselves. Thanks for tuning in to the Midnight Medic Podcast.